anything that you could really think of, breakfast on the go, a stop after your workout, or sitting in traffic and something to go with. It's real fruit in yogurt, and you can get that at many outlets around the country, and that's Delamere, with real everything, and it's premium. Don't jealous me. But what you can tell me about CT is how I can have a mortgage where I can have my yogurt in my own home.
Okay. You see, when you talk mortgage, you're talking house, you're talking structure. Okay? And if you're talking structure, for most people, it is something that you dream about, something in the future. Now, Diamond Trust Bank are saying, look, this future thing is all good and well, but can we bring this thing a little closer to you? So something you can relate to today going forward. And they're saying, look, if you visit any Diamond Trust outlet, if you email mortgages@dtbafrica.com, there'll be a lot of information. Now, let me tell you about this information that you will get. Okay. You will be told the following. One, you are able to procure a mortgage whether you are employed, whether you are in business, whether you are in the diaspora. Let's start with the diaspora. If you're in the diaspora, you can be afforded a mortgage of up to 80% of the value of the property that you wish. Of course, pegged to whatever it is that you're earning. Remember, your earning determines what it is you can borrow. Yeah. Because it determines what you can pay. If you are in business or you are employed, ETB is saying, look, we can give you up to 105% mortgage. Mortgage, yes, 105%.
Really pretty.
No, that is pretty pink and smiling at you. And they're also saying this, that we don't have any hidden charges. We're not going to suddenly spring and hit you on the head with something that you hadn't anticipated. And if you choose to pay early, we're also not going to penalize you for paying early.
I love this kind of thing.
Yes. Just give it thought. Take a deep breath. And you may ask, but surely, does that not sound a little too good? No, it doesn't. DTB has partnered with Kenya Mortgage Refinance Company. And because of that, they're able to offer you this loan. If it's for 10 years, this mortgage will only be charged 9%. If you take it for 25 years, you'll be charged 9.75%.
But it's fixed. It's not going to do somersaults and go crazy.
It's not 9.76 tomorrow.
Okay.
It remains that way. Fixed meaning doesn't move. Come shine or rain.
Thank you so much for making my morning.
Mortgages at dtbafrica.com.
Fantastic. And also getting into the place where we can talk about, the 1 million people who enter into the job market every year. What's good for them?
Well, since we're not taking away sunshine, let's bring sunshine.
Okay.
Now, KCB, since 2016, has been bringing sunshine.
Okay.
And it has brought sunshine.
At some point, we'll learn how to speak on this show.
150,000 people have gotten jobs because of this sunshine. And youth trained have been 35,195. Businesses incubated have been 10,000, and 267 million loans to support their enterprises. If you assume each loan was just 10,000 shillings CT, we shall learn to speak. It shall be 2.67 billion shillings given out. If it's just, if it's just 10 shillings, oh my goodness, imagine. So this is a serious amount of money that has been given out, and all you need to do is look out for when the window opened yesterday. We were told they'll be ready sometime later this month. You go on to KCB Group /foundation and join the how many 35,000 other people who've been trained and have become successful through what KCB has done.
Fantastic. I mean, it's a lot of things happening, and it's really great to always see that, folks at one point or another can get the much needed leg up that they need. It is our Healthy Friday conversation, and our guest is already seated in the hot seat. Dr. Manel Haj is a consultant medical oncologist at the Aga Khan University Hospital, and we're looking at World Cancer Day, United by Unique. Dr. Haj, good morning.
Good morning.
How are you?
I'm fine. How are you?
Very well, thank you. Welcome to the hot seat of the Situation Room. We're talking hot topic today, cancer, a big one. World Cancer Day brings us to look at, quite a number of things. And as we get into that, obviously, you're very well placed to have that with us. So, Karibu Sana. We're going to welcome you to the Situation Room with a proverb which CT brings from different countries in Africa every week. And we've been in a very interesting country this week. So he's going to share the proverb and you tell us what you think of that and how you would interpret that. Is that all right?
That's okay.
Okay.
Okay. This country has a capital that is known as Djibouti City. Which country is it?
Djibouti.
Okay. A good
Off to
doctor
a good
here.
start.
No, she paid attention in her geography classes. This is good. We're on to a good start here. Okay. We do not kill a dog because of its barking.
Okay. I can already feel the heat of the room, of the seat.
Should we switch on the AC for you?
So the way I look at it is that if you have an issue, take it from the root. So you don't solve a problem by just, or actually no. So you don't solve a problem just because of its noise, but take it from the root, and then make sure that when you solve the issue, you solve it properly.
I love it.
Thank you.
Yeah.
I love it. So a dog is barking because of something.
Yes.
Yeah.
A dog doesn't just bark because it's bored. Right?
Exactly.
There's
Yeah.
something that's causing it to bark.
So you
go
have to look
for what that issue is.
beyond the barking. Yeah.
I love it. Okay. City, say something.
Well, we did say that dogs have strange habits. Among the strange habits they have is the chase cars.
But they are friendly.
They are. Yeah, so if a dog barks at a particular time, that maybe there's something that has bothered it, go look for that thing.
Exactly.
You know, look for it. So the noise around something is just a noise. Go
And
to
this
the root
noise
of
that
the
we-
problem.
This noise that we use, the word noise we use to describe a dog's barking, that's a dog communicating.
It's communicating, absolutely.
Yes.
Yeah.
Yes.
Kind of like a baby, they say a baby has different cries.
Oh, they do.
Yeah, there's one
Oh,
for
they
hunger,
do.
one for
Oh,
uncomfortability.
they do.
Yeah.
They do. There's one for attention.
Yeah.
They do.
Okay. Great to go into that today. So there's a lot of noise around cancer. There has been for a few years. If we look at it specifically towards Africa, cancer was not as big a problem 20 years ago as it is today. But now we're looking at World Cancer Day and taking the globe into perspective. But just let's look at some markers, starting off with you, in terms of where are we as far as the burden of cancer is concerned.
Yeah. So, cancer, when patients ask me, why do I have a cancer? Why do I hear about cancer? At least every person has someone in the family, in the neighborhood, who has a cancer. So the way I look at it is cancer is the new diabetes. It's there. We have to accept it. We have to try and do our best to prevent it, but then also to treat it whenever it's diagnosed. So it's the natural history of cancer, and it's the natural history of any developing country. Initially, you focus on the communicable disease. Now, once it's sorted, you look at the non-communicable disease. So, of course, 20 years ago, the focus was mainly on TB, HIV, diabetes, chronic illness, cardiac disease. But since those ones, the health system is on top of it, kind of. Now you need to also let your health system improve and then also evolve with time. And now more critical and then more special illnesses are being looked at. It's a global phenomenon. Cancer is increasing in developed countries, in non-developed countries, in poor countries. It's just that we feel like the numbers are increasing, and they are, but it's due to many factors. Some of the factors are that now we can diagnose a cancer. Before, people would die from something, and if no investigations is done, people would think, okay, it's age, it's TB, he just fell sick. So people wouldn't give it, wouldn't call a cat, but this probably was a cancer. Now, in view of the improvement of the diagnostic modalities, imagings, biopsies, everything is available, and awareness of the health system, the doctors, the doctors, the nurses, even the patients, the community, we see more and more cancer.
Right.
Yeah.
Are we getting proper diagnoses of cancer? I mean, I remember us sitting in this room a couple of years ago, and we read a story about a gentleman who had what he thought was a flu. So he would go back, and it was constant, I've got this flu, there's congestion, and they said, well, it's just a sinus issue, and after that, maybe it's an adenoidal issue, back and forth, until he went back and did a second and third callback, and he had esophageal cancer. It's the 4th stage, So are we diagnosing properly to the point where we say it's rising, but is it possible that there are those who are sitting with cancer but are being diagnosed for something else?
Yeah, definitely. Those scenarios are still there. We are not at the level where we want to be honest, because when we see, by the time the patients reach out to a specialist, to an oncologist, for example, or a tertiary hospital, when you look at the history and when we take the history, you find at least those patients have struggled for 3 months before coming to the right place. So those scenarios are still there. It depends on where do they start from. So sometimes, when you start from a rural area or from the frontline health systems, sometimes we feel like there is, it's easier to call it TB, it's easier to call it a flu, rather than think about an underlying issue. And then the problem is that sometimes we feel like the patients go from one facility to another. So let's say, for example, he went to the first facility, they told him it's flu, they gave him medication.
Yeah.
If there's no improvement, if you go back to the same facility, they might be able now to start looking at other differentials, and cancer might be one of them. The problem is that the patients, go from one facility to another, and then sometimes you find yourself repeating a first blood test, then a second one, then a third one, even scans, imaging. So there isn't really, there isn't a continuation of the process of investigating. But then also, cancer is still a taboo somehow. So sometimes you find barriers coming from the community or from the health system. So there is lack of awareness. Some patients might fear the diagnosis, and then when they feel like the doctor that they are seeing is heading to inform them that there is diagnosis, they fear it, and then they just run away. Or they want a second and a third opinion. Because sometimes I also receive patients asking me, like, are you sure it's cancer? Are you sure it's not TB? Can you please look for something else? Can you please repeat my biopsy? I don't trust the other facility. While in fact, it's just the denial. When you announce a cancer, people sometimes fear the diagnosis. They immediately think it's a death sentence. And then sometimes they spend their time trying to find someone who can tell them otherwise. Yeah.
There's always the question that arises about cancer. And the relationship that cancer has with pain. When one has, whether it's the onset of it or the progression of it, is pain a significant indicator in understanding cancer?
Yeah, that's a good question. So usually when the patients, I'm just bringing examples from every day. So when patients come, they have spent maybe like 7 months seeing a lump growing in the breast. There is painless. And when they come to you, they're like, but I didn't have pain. And actually, that's the trap. Cancer, when it grows, it doesn't cause pain. So people tend to neglect it. It's like, okay, I have a growth, but it's painless. Why should I go and see a doctor? So in the very early stages, cancer can be silent. You might see the growth if it's on one of the external organs, like a breast, a limb, but then you might not even feel it. For example, a lung cancer, it can grow so seamlessly that no one will detect it. And once it's detected, it's at a very late stage. While some other tumors in the brain, immediately the growth starts, the symptoms will start. The pain, the headache will start. So it depends on the location of the cancer, number one. Number two, the very first stages, it's really painless. Now, towards the end or end stages, that's when it becomes painful. And that's actually what we want to prevent. So if it's diagnosed at an early stages, cure can be offered, treatment and getting rid of this cancer can be really offered, and we want to avoid those kind of complications like pain, other complications like bleeding, affecting a vital organ like liver failure. So that's the whole purpose of the treatment. So that's why we want to encourage and we want to increase the awareness so that cancer is detected at the very early stages. And then some of the cancers we can even prevent them. So the earlier the better. If you prevent, that's a win. Even if you detect at an early stage, that's also a win. Yeah.
You know, the understanding of even what cancer is in this country and what causes it is a subject of big debate. So, for example, there was a movement that we should not microwave our food because it will cause cancer. There's a saying that if you take some certain drinks, you'll get cancer. And then the understanding of what exactly is cancer. So when I go to the doctor, the last thing on my mind for anything is cancer. So perhaps a very simple explanation of what cancer is and what are the likely causes that you've seen in your practice that Kenyans maybe are exposed to that are causing these cancers.
Sure. So to try to simplify it so that any person can understand, a cancer is a disease that starts from one abnormal cell. So basically, all of our cells are aging. We have new ones coming. So there is a continuous process where there is a cell multiplication in our body. So one day an error in the DNA might happen, and then it makes an abnormal cell appear. Now, a normal body and a normal immune system is able to detect, and this phenomenon happens quite often. So a normal body and a normal immune system will be able to detect that abnormal cell and then consider it as a non-self cell and get rid of it. So you need to have many factors. Number one, for that cell to appear. Number two, for that cell to multiply and continue growing. So either an immune system there is not functioning well, and this could be from a hereditary genetic condition, or the abnormal cell to appear and then to persist. The patient could have an abnormal immune system, so immune compromised. Patients, for example, who have chronic illnesses, who are on many medications, who are on medications that suppress their immunity, HIV patients, hereditary condition that makes the immune system abnormal. To have that abnormal cell, so many, you have to have been exposed to carcinogens, like, for example, smoking tobacco, drinking a lot of alcohol, having an unhealthy lifestyle, no physical activity, eating junk, sitting a long time, a lot of stress at work. And there are some familial conditions. So you look at the family and you find there is a significant family history of cancers. The quality of our food, the quality of the plastic and utensils and the things that we are using. So all of those are factors that when you put them together, the person can develop cancer.
And so then looking at the same factors that could predispose one to cancer, then is that now where the preventability of all of this comes from? If you take into consideration all of these things, what you eat, how you move, your family history, how you store, prepare your food, if you take all of those things into consideration, is that the premise that we work on to then say that cancer across the spectrum then is preventable?
Correct, yeah. So, for example, cervical cancer, it's number 2 cancer in Kenya, as just a matter of example. We all know that it's a human papilloma virus that induces the cancer. And number 1, the vaccine is available in the country, and the intake is just too small. Vaccine is available, it's free in the government hospitals. There are many options to try and prevent or at least induce a good immune system to prevent the infection to HPV, to lead in the next 10 years to cervical cancer. So it's something where you have many years to prevent it. do the vaccine before the little girls start having a sexual life. So you can start it at an early age to prevent them. So even if they are exposed to the virus, at least they have a good immune system, and then they will not end up having a cervical cancer 10 years later.
Which is the number 2 killer in the country.
Exactly.
Is it number 2 or number 1?
It's number 2 after
It's
breast
not-
cancer.
So in terms of incidence, it's number 2. Yeah, even in terms of mortality, it's number 2. Number 1 in Kenya is breast cancer. Now, if you try to talk about the whole region, cervical cancer comes number 1. Because in the neighborhood countries, it's really number 1 cancer. Yeah, but it's still one of the cancers that really you can prevent, number 1, but then once it's there, the outcomes are not that good, especially if the patient comes at a very late stage. Yeah.
Okay.
Aflatoxin, for example, talking about food. I know everyone loves ugali. Everyone loves maize flour. But then you need to know from where you're buying it. You need to know how to store it. You know, people harvest their own maize. We don't know how they store it at home. With a lot of humidity, that makes the aflatoxin, it makes a very good environment for aflatoxin to grow. Now, you're taking that ugali every day. Of course, it will lead to some cancers such as liver cancer, esophageal cancer. So smoking street-made tobacco, for example, or even the branded ones, and then you do it every day. So you make a prompt environment to the abnormal cells to appear and then keep growing. So obviously, many cancers we can prevent. Now, someone who has a family history of colon cancer, for example, you look at the family tree, you find that this cancer does not skip any generation. Of course, you start your colonoscopies at a very early stage. You do your screenings regularly, religiously, so that in case a precancerous condition appears, we treat it before it becomes cancer. Family history of breast cancer as well. Let's say we don't have any family history of breast cancer. Did you know that 1 lady out of 8 will end up having a breast cancer? So
Without family history.
Without family histories.
Jesus.
That's a,
1
that's a
lady out of
very
8 or
big
9,
number.
yeah. If we are 8 in one room, one of us will have breast cancer. So start doing your mammograms from the age of 40. And do it regularly every year.
Okay. Are there things that would definitely tell you something is going on, even if if you're aware of your health? I mean, I had a friend who passed to lung cancer last year, and when we think about it, when she started to tell us, over time that, I've lost a lot of weight and I've not necessarily been working out. I've not really changed anything in my diet. Started to feel off every now and then. Later on, then you realize, okay, actually, this could have been something because, like you said, it was painless. She had no pain for 8 years. She had nothing until this weight drop and then this feeling of malaise, all the time. And then going ahead and starting to do some tests thereafter where it was found that she had stage 4 lung cancer. So the question is, are there markers? Will you see something, even with the painless period? Will you see something? Will you know something that would, say, okay, perhaps there's something here that's not wrong? Because if it's painless, and that's it about us, isn't it? Is that if you don't feel any kind of pain or uncomfortability, the likelihood of you to rock up to the doctor's office is low. So would there be something that would show you, that would trigger you that, there's something wrong?
Yeah, so cancer can be detected through several symptoms. So it doesn't have like a one classic scenario. It can show in any way. One of them is just weight loss. So if someone is having a weight loss that was not planned for, and like you said, the diet did not change, we should do some blood tests. We need to run some blood tests and then run some just basic investigations, and then we'll be able to detect. But the key word here, maybe she has noticed the weight loss and then she didn't go and seek help. So they didn't go and see a doctor, for example. Weight loss is really a general symptom, but should be considered seriously if it's persistent and it's really not planned for. She could have had a cough. I don't know. I'm just saying. Yeah, she did have a cough. So a persistent cough should be investigated. Why would you be having a cough and it's persistent for more than 2 weeks. Okay, a cough that follows a flu or a cold or a pneumonia, you can allow it to stay 2 weeks, but beyond 2 weeks, it's not normal. So you need to go and have some imaging on the chest, make sure that there is no growth. Do regular checkups, do annual blood tests or annual checkups, just to be sure that you can prevent other problems. Now, a simple blood test sometimes can tell us more than what you think, and then we might start detecting abnormalities, and then you start one step after the other that will lead you to the main problem, to the root of the issues. For example, someone who is coughing blood, it's not normal. Well, if you see a blood, it's not normal. A new growth, it's not normal. Abdominal pain, vomiting blood, those are not normal symptoms. Blood in the stool, also those are not normal symptoms. So once those symptoms start and a patient or a person see it, medical attention needs to be sought, yeah? Now, to prevent, because once you reach those symptoms, cancer is there.
Yeah.
But then if you want to really prevent, if you're aged 40 and plus, do a colonoscopy. And then the gastroenterologist will guide you how often do you need to do it. Do your mammogram. Do annual checkups. Do blood tests. Sometimes even blood pressure or diabetes. I mean, it's sad to find someone coming to your clinic because they never stepped inside any hospital. They come for other issues, and then you discover that diabetes might have been there for years. They come with, for example, a side issue. And then you just try and do your investigations, and then you find that this person had diabetes for a long period of time. They will tell you, yeah, I always felt thirsty. Yeah, I wake up at night several times. So do regular checkups, and that's how we will be able to detect problems early enough to be able to treat them, prevent cancers, or even prevent other health conditions.
Okay.
Yeah.
Our Healthy Friday conversation this morning is with Dr. Manel Haj, and we're looking at, around the intrigues of cancer today on World Cancer Day, united by unique, so many things that we are getting information about this morning. We're going to continue with that conversation when we come back from this break. It's 28 minutes to 8.
Alexa?
Max, I got kicked out of the mansion.
What? Does Pops know?
Yeah, and he's the one who told me to just do as they say.
So what's the plan now?
I've got to lie low. I'll recharge. And wait for what happens.
All right.
Please, Aiden? I'm currently with Aiden. He says he'll keep me safe.
Why did she go with that guy?
Aiden's the one who needs to watch out around her.
When I have back pain, I reach for 2 tablets of Panadol Extra. And I am finally released from pain and ready to be there for those who need me. Try Panadol Extra for fast and effective relief from strong pain.
Watu wangu, Januari bado inawapelekaje? Sasa, this round This round sijakuja na pesa kidogo, nimekuja na 1 million. Hii inaendelea kwa hii promo ya Furahia Januari na Daka. Niko na good news. Umeshinda 1 million. Ido, utaitumia kufanya?
Aido ndaza kuextend hiyo biashara yangu. Niko na place naza wasiwe naza kulia nyama.
You know, when you talk about those symptoms, I'm sure that people who are listening and they're diabetic, they're hypertensive, or they're generally, they smoke. And maybe some of those symptoms are ringing true. The question is, where do you go? Where do you go? Do you start at your dispensary, where you go to your clinical officer? Do you go to Kenyatta Hospital immediately? If you have symptoms that are worrying you, a cough that has stayed a long time, where exactly do you go?
Yeah, I think, you know, nowadays in the countries we have, in the country we really do have specialists somehow covering all counties. So let's say, for example, you have a persistent cough. The best is to go and see a pulmonologist so that they can do thorough investigations and make sure that this cough is either a benign condition, such as asthma, for example, or TB, or a malignant underlying condition. Abdominal pain, blood in the stool, persistent dyspepsia, persistent heartburn, weight loss, go and see the gastroenterologist. So those who don't have immediate access to the specialist, at least you can start with the physician, and the physician will definitely orient you to where to go. The patients who have diabetes, high blood pressure, they all have their either family physician or general practitioner or endocrinologist and or a cardiologist that is looking after their condition. Those specialized doctors will be able to orient you and put you on the right circuit from the get-go. Yeah.
Okay. So basically, just for understanding, one, see your doctor. If you have a persistent issue, get a doctor who's a specialist with what you have as an issue. So whether it's your stomach, your head, your eyes, your whatever, see the doctor who's relevant to that. And then that doctor, if they don't find a condition that is normal, they will then refer you for cancer screening or something like that.
Yeah, so we really have a methodology to look for the most common conditions, starting from the benign one to the malignant one. So, of course, you rule out what is urgent to be ruled out, such, for example, an infection, which is reversible, and it has to be immediately treated, yeah? But then even if you treat it and then things are persistent, or you detect some abnormalities in the blood test, that's when you start thinking of other conditions. So usually when you see a specialist, when you see a physician or someone who really, who is really subspecialized on that complaint, we usually have a methodology on thinking of like more than just one diagnosis, yeah? From the most common one, the most probable one, to the unprobable one. So even if cancer is the unprobable scenario, in that case, someone would have thought of it.
Okay. All right.
Okay. So this is interesting because as we talk about prevention of cancer, one of the big issues is screening. But, a lot of our folk, we are worried about, number one, the cost of screening. Cost for screening of cancer is still pretty high. We did hear about an intervention a couple of months ago for cervical cancer where they used, I believe it was the vinegar color test, which was, relatively cheaper than any other kind of screening, for example, a pap smear, But if we talk about 2,000 shillings, which now some organizations are able to do a pap smear for a lot of people, for very many people, that is still very expensive. And I want to park that and then bring in a conversation that we had the other day on research, where a lot of stuff is being done and how they need to then be supported for some of these things that we speak of. So even as we celebrate or commemorate World Cancer Day today, one of the big things is screening. Are there moves in the direction of making available cheaper screening mechanisms for people to then, take advantage of?
Yeah, so that's really a good question. And I think people need to know, if you find screening expensive, you have no idea about cancer treatment. So you better prevent it than treat it. So, and in terms of screening, it's just, a one-off. Not really a one-off, it's a regular screening, but then, it happens once a year or once every 2 years. You'll be guided by the doctor. But trust me, preventing cancer costs much less than treating cancer. So we need to invest on screening. People need to go for their screening. And actually, majority of the facilities are doing screening. I mean, of course, I work at the Aga Khan University Hospital. And then just, for example, this month, we are offering 50% on all modalities of screening. Pap smears, mammogram. We don't really screen for prostate cancer, but even PSA blood test is a bit cheaper. So take those opportunities, follow, because many hospitals, many facilities, many insurances are actually helping the population to access screening. So just ask around. You will find that there are so many options if you really want to stick to the screening. So preventing is always better than treating on all aspects. On your pocket, on your health, and then also on your outcomes. So screening, I don't think screening is really expensive. And it is accessible, and we have many options. As doctors, as a health care system, we want to increase awareness, and we increase awareness through the screening. So many doctors will volunteer. Many doctors will be doing campaigns free of charge, go deep into the rural areas, go deep into, it doesn't have to be in Nairobi only. So we visit counties, we give free of charge talks. We also offer tests whenever it's available, and we see the impact. Let me tell you something. At our tumor board now at Aga Khan, we are still seeing the patients that came for the screening in October for breast cancer screening. And you can't imagine the wonderful number of patients with stage 1 cancers we are seeing. They just came for the screening. And usually, it's really sad that we see a peak of stage 1 breast cancer. So they start October, November, December, January, February. Now we are discussing those stage 1 cancers. And the treatment will be just surgery and then hormonal treatment. Less or minimal of them will end up doing chemotherapy. So imagine, it's just wonderful. You diagnose a breast cancer at stage 1. You don't give your patient chemotherapy. Treatment sometimes will stop at surgery, radiation, and hormonal treatment. And you tell them, congratulations, you're done with your treatment. Your survival is more than 90%. You join the normal population. This was a short period in your life. Better than having someone come on stage 3, stage 4. Stage 4, now you tell them, I'm sorry, but this is a lifelong treatment. You will always be on treatment. Right. So the scenarios are completely different. And now, so since we have seen the impact of the discount that the hospital offers in October, now we are doing it twice, October and February. And it's the same thing that will happen. March and December, we will detect many precancerous conditions, many stage 1 conditions. And it's just wonderful. You feel like you've helped preventing so many complications to your patients.
There's a statement you've said thrice now, pre-cancer. What is that?
So, when you do, I'll just focus on breast cancer. I'll just use the 2 most common cancers. Breast cancer, okay, let me use 3. Breast cancer, cervical cancer, and prostate cancer. All right. So for breast cancer, we know there are some precancerous conditions. Just for example, what we call an in situ disease, DCIS, yeah? So it didn't breach the membrane, and it didn't become invasive and become a cancer to spread. And that's something you can just treat with a surgery. You just remove it, and it will not move to the next step, which will be cancer. So you detect it just by seeing some abnormal calcifications on the mammogram. You go, you take a sample, and you find the DCIS, ductal carcinoma in situ. So it's still contained. It didn't spread yet. It didn't become an invasive condition. Cervical cancer. So we know which of the viruses are behind the cervical cancer. So when you do a pap smear, sometimes you start seeing an atypical cell, atypical cell on your smear, and then you know that this one in the next couple of years will become a cervical cancer. So you can treat it from that stage, and it doesn't have to entail chemo or radiation, so you can just treat it. And then in terms of surgery, we have many options, from the less invasive one to the complete removal of the uterus, depending, of course, on the stage of that precancerous conditions. Prostate cancer, for example, if someone has a family of prostate cancer, or let's say without family of prostate cancer, and then they have some urine issues, go and see a urologist. They will do what they need to differentiate between a benign hypertrophy of the prostate or prostate cancer. And then let's say the diagnosis, so immediately you started having urine issues and you went to see the specialist. They will do some investigations, screen for infection, number one, make sure that you don't have a urine retention. But then one of the investigations, when it's the right time, would be to do a PSA. If the PSA is elevated, now that's when you start asking for scans, ultrasound, MRI if need be. And if suspicion of cancer, we take a sample. Now, if you did that early enough, sometimes we end up diagnosing prostate cancer and we don't treat it. We just observe it. We do what we call an active surveillance. So we can offer you 3 years free of any treatment, free of any complications, but you are under thorough follow-up and thorough surveillance. So when it's time to treat it, that's when we treat it. And then even when it becomes 3 years without any treatment, and then let's say the status has changed and you need treatment, it can still be cured, you can still be offered surgery. You don't have to really, you might choose between surgery and then all hormonal treatment and radiation because it's an early stage and you have the luxury to choose the option you want. But it's better than, coming at a late stage where the only option that you will be offered is possibly chemotherapy, for example. So we can prevent so many things by showing up on time.
What are the chances of relapse even after a state of remission, for example, has been pronounced?
What is remission?
What is remission? Okay. So remission is when you have a patient that had a cancer, received treatment, and then remained at least 5 years with no relapse. Those ones you can call them remission, patients on remission. And there are so many cancers that we can cure at a rate of more than 90%. Cure, Like, for example, let me just bring in some examples. There is one type of blood cancer called Hodgkin lymphoma. Hodgkin lymphoma, when it's detected from stage 1, even up to stage 3 and even 4, you can cure them. Of course, the earlier you come, the higher are your chances of cure, and then the less are your chances of having a relapse. Testicular cancer. I remember last year I came here and we talked about testicular cancer. It's one of the cancers that can be cured at more than 90%, such as Hodgkin lymphoma as well. So those are like good prognosis cancer. So, but all the conditions should be together to be able to offer that cure to your patient. So treatment is available. That's one condition that I can tell you we can tick. Surgery is available. We can tick. Scans, PET scans, wherever the patient needs in terms of investigation, available, can take. Now we need patients' awareness and we need them to come on time. Now, when we achieve that, of course, those types of cancers will be seen at an early stage, will be treated, will be cured. Patients will be slowly going back to their normal life.
So then how come...
Right,
yes. So then we do see cases of relapse after remission. What are the chances of that, and why is it then? And I mean, that question, then I've just seen a question here from Agola as well, that why then do we see that cancers come back more aggressive even after that?
So more aggressive, I'm not really sure about it. I don't think there is really evidence confirming that it comes back more aggressive, but few scenarios we have explanations. Why do people relapse? Unfortunately, the relapse rate in our setting here, it's quite significant because when you look at the initial presentation, patient has already presented at a very late stage. So, and I usually inform my patients about that. So like if they come at a stage 3 and the disease has already spread to the lymph nodes, and you look at some risk factors like the proliferation index on the microscope, the grade, how aggressive is the tumor, and then the stage plays a major role. So, for example, let me just talk about breast cancer, for example. Stage 1, like hormonal type, chances of relapse is between 10 to 20%, less than 10%. Let me put it less than 10%. Stage 2, chances of relapse, 20%. And I'm talking about the next 20 years. I'm not talking about the next year. Stage 3, between 20 and 40%. So the later you present, the higher you increase your risk of having relapses. Also, the patients who are relapsing now, they may have not received the appropriate treatment 10 years ago, because the drug might not have been available in the country, number one. Number two, the treatment paradigm changes and evolves. Some drugs were not discovered 10 years ago, and they are discovered now. So the outcomes are changing. The improvement of the outcomes, the reduction of the risk of relapse is improving. But one important condition that we all need to put our hands together and make sure it happens is early presentation.
Okay, so I've just got to jump in there, because when we talk about early presentation and we're looking at some of the numbers, when we talk about, the cancer burden in the country, sadly, and I don't know if this is, it's like a last 2024 number, but 70 to 80% of the cancers diagnosed in Kenya today are diagnosed in their late stages, and late stage 3, 4. Right? But we're saying that and we've talked to medical professionals who will say, yourself as well, who will say that medical care in Kenya has to now start to focus on the preventative as opposed to the curative, because then, number one, it's cheaper. Number two, the quality of life that is preserved is much higher on the scale. But we still have that very high number, that 80% of those that have been diagnosed are diagnosed in the late stages, even with the push towards preventative health care. How? And I know it must be a difficult question, but how are we going to then bridge that gap?
Awareness. We need to increase awareness. So we need, like, for example, this session. I'm sure it will reach many houses. And I'm sure even those who were not aware of, cancer can be treated, cancer can be prevented, cancer can be, it's not a death sentence. Options of treatment are there. People continue with their normal life. So this will encourage people to go for their screening, will encourage people to reach out if they have any issues. Maybe as we are speaking now, someone has a breast lump, and then they realize that they need to go to a nearby facility, and they will do it tomorrow. So increasing awareness is the key. We need to reach the whole of population, from the most, from the capital to the ruralest, to the most rural area. Yeah. So increasing awareness, and that's what we are trying to do.
Okay.
Yeah.
Why do so many people go out of the country, specifically to India, for cancer care and cancer treatment?
Okay. So here I'm giving my objective opinion.
Okay.
I'm not Indian, I'm not Kenyan, so I can be objective.
Yes, you can. Me too.
So I don't know why I feel like there is, people look high at overseas options, and I don't know why it is being put in there. It's a mentality, basically. People think that Indian treatment is much better than what can be offered here. They are the best doctors, they have the best options, while here they look at it differently. And it might have started like many years ago. I don't think it has come now. But I'm clearly seeing a change of the mentality when people come to us. They understand, we explain to them the treatment, the options and everything. They feel like, why do I even have to travel overseas? Everything is available in my own country. Let me be surrounded by my family and my beloved people while I'm walking this journey. Let me not walk this journey alone. But I agree with you, some people are still thinking that, maybe when they go to India will be better. But now I think the people who are going there, they know that things are available here. It's not like before where maybe a few things were lacking. Now we almost have everything. Let me be honest. Whatever is missing is really minimal. And I know a lot of efforts are being put to even those minimal, sophisticated procedure will be available here with expertise and with experienced people. So I know what we are doing on the background and what we are trying to improve, because also as a doctor and as a healthcare provider, you want to offer your patient the best. And we are really working hard on it as, many societies, surgical societies, oncology societies, to improve our services. So a lot of hard work is being put. But to explain the overseas travel, it's before it used to be done because there were so many gaps in the country. Now, honestly, things have evolved so rapidly in a short period of time. In oncology management, I don't think we have several gaps, just like 2-3 minimal things that we are yet to have, but we are working on it. But people might travel, mainly the cash payers might travel because of the cost. So cost remains also an issue. So, in India, they have a lot of competitors.
It's a large country.
It's a large country.
Many people. They are much richer than us. They have more facilities.
They have more facilities.
Yes,
yeah.
and also when you have that huge population, many of whom are poor, the incidences of ailments that you come across are more. So people in that particular field will have had a much broader experience with dealing with those things than here. You see, the question we ask can be asked of our neighbors. Many people in East and Central Africa come to Kenya for treatment.
And that's a true statement. Yeah. So I see a lot of patients coming from Tanzania, Uganda, DRC, Burundi, Rwanda. There are many. So those people have realized they don't have to travel to India to get appropriate treatment. So they come to the closest country.
Right.
And they are really happy and comfortable and have all the reassurance to be treated here. Yeah.
I mean, even as we raise awareness, I mean, just to get down to the humanness of all of this, especially when we come to preventative care, and you talk about screening, just looking at some comments here, and also just from what we've heard, is that even if you do have the money for a screen, you don't want to know the outcome. So the fear of outcome is a real issue. How do we get that out of the minds of people that you do want to know? It's prescriptive. You want to know what is going on, if there is. How do we deal with that?
Yeah. So just going back to the topic, I really like the United by Unique because that's exactly what we see with our patients. So they all have the C word, cancer, how people like to name it. They all have the C word, but they are all unique. So some of my patients started with that fear of cancer. So like the first thing, they will be coming to you and tell you, please don't tell me I have a cancer. But then they make it their strength, and then whatever they went through, they don't want anyone else to go through. So like some of my patients, for example, they made it out of a breast cancer, and then they realized that they need to help the doctors and increase the awareness. They have created patient support group. One of my patients, just to say hi, they have created Cancer Must Go, and she's put in a lot of efforts to make sure that the people surrounding her, because she's a young lady, the people are like young patients are aware of cancer. They don't fear cancer. She's sharing her experience, and she's sharing with so many other patients' experience to tell them, this is what we went through. It's not a death sentence. It was actually a journey. When I look back at it, has helped me with a lot of confidence, strength, and I want to transmit what I learned from this journey to other people and make sure that they don't fear it. And then go and seek help from the health system. Be strong. We are here with you. We are helping you. So I think, and I think I've lost the question. The question was?
I mean, how do you deal with that?
How you do?
To get over the fear. Yeah.
Get over the fear, yeah. So, you know, the first clinic, when they come to us, they are in a lot of fear. But then after that, you know, they accept it. Initially, that's the natural reaction. So you are in denial, then you have a lot of anger, and then you accept it, and now you keep moving. So we need to respect also all those phases, but then we need to make sure that we help them get out of the first phase, which is the denial and the anger, as soon as possible. So that's a normal process of, that is the normal way of processing that information of having a cancer. But patients really need to know that cancer is not a death sentence. I mean, if I put all cancers together, and if patients come at an early stage, I'm talking about a cure of around 70 to 80%. So, and I keep looking at cancer nowadays as cancer is the new diabetes. People before used to fear diabetes, right? Like, don't tell me I have high blood pressure. Don't tell me I have diabetes.
I still
now,
fear diabetes.
Cancer is everywhere, and many options are available. So you better catch it at the root, like the first proverb we started with.
Yes.
And then you start working on it, and then the outcomes will be much better. Even better if you prevent it. So we have campaigns for preventions. We have campaigns for awareness. Take those opportunities, use them, do your preventions, do your screenings, and then you might even avoid having a cancer, prevent it happening at all. If you really fear it, put all your efforts to prevent it.
World Cancer Day is united and unique and ways in which you've been able to spread that information. And it's important that we continue to talk about these things. It's too big a burden not to, and but then also seeing that there are interventions that can actually save life. Dr. Manel Haj has been here with us this morning. I want to thank you for being here on our cancer conversation on this Healthy Friday. She's a consultant medical oncologist at the Akan University Hospital, and we've gone through those issues today, commemorating World Cancer Day. I want to thank you once again for being here today. Asante Sana.
Thank you.
Good morning. Conversations continue. It's 8 a.m.